My name is Sandra Adams. I'm here today to do my senior presentation. It's going to be about saving cardiac muscle by attention to detail. I've been a nurse for about 20 years. I've worked in the medical field for about 30 years. And during that time, most of it's been cardiology. I've had the privilege of working in multiple cath labs, of which include St. Francis in Columbus, Georgia, University of North Carolina, Chapel Hill, and Northside Hospital in Atlanta, in which we took call and cared for patients coming in with acute MI or STEMI. And as we go through this PowerPoint, we're going to talk about some steps that we can add to save heart muscle. I'm going to go ahead and start with the abstract and talk about it's 720,000 people every year have a heart attack. It's pretty a large number of people. We know that it takes about 90 minutes or less from the time the patients hit the door in the emergency room to having the balloon inflated in the artery to have success. And if it's more than that, then we have tissue damage. So we want to maximize every available minute. So if we have 90 minutes and we've used 10 minutes from the time they hit the door, you now have 80 minutes. That's something to keep in mind. So what I propose, or what this abstract is about, is that we're going to implement a team, and we're going to get this team together and evaluate the steps that are already being done and how we can add the additional 4 steps, and then evaluate those outcomes quarterly. The steps are stripped, clipped, saline, and padded, and we'll talk a little bit more about those in the next slides. Patient arrives at the emergency department. 10 minutes after that visit, the patient is diagnosed with a STEMI, an ST elevation myocardial infarction. Chest pain protocol begins, and at the time the chest pain protocol begins, cardiologist is notified, the cath lab team is notified. This team sometimes is 3 people, sometimes it's 4 people, it varies. But at that moment, they have 20 minutes to actually get to the hospital and get ready to receive this patient from the emergency department. So we have 90 minutes or less. We've used 10 minutes of it. Here we are at 80 minutes. So now we're going to go to the next slide, and we're going to look and see that we have a confirmed STEMI, means that an EKG has been completed, and you have ST elevation in more than one lead showing that there's a heart attack. So the next thing you're going to do is go to the telemetry, and you're going to start putting on your electrodes. But the first thing you have to do is you have to have that patient take their clothes completely off and put a gown on them, and we're calling that stripped. At this process, when they're putting the gown on, this is going to be the time where you put your electrodes on for telemetry. I'm saying go ahead and add the step of adding the defibrillator pads. So put the pads on the right upper shoulder and the left lower chest, and this enables us to use the fluoro, and we don't have the pads in the way of the x-ray machine. But if you put them on wrong, then we have to take them off and reapply them, so that doesn't really save any time. So it's important in doing these steps, we do them so that it's best for the patient. The next thing you're going to do is go ahead and shave the patient's groins on both sides. We use electric clippers. We don't shave anymore, but we do use electric clippers. Go ahead and clip enough area that you have a good pulse on both sides, and you can feel that femoral artery. That gives the physician good access. The next thing you're going to have is usually your nurse or your team leader or your nurse that's in charge of this patient is going to implement the chest pain protocol, which includes MONA, which is morphine, oxygen, nitro, and aspirin, and that's already involved. That's already going to happen. So if you're already implementing those steps, when you're hanging that nitroglycerin, go ahead and hang up a full liter of normal saline and having an IV line that has multiple ports. That'll help us because we're going to be using all of those ports with the heparin or ReoPro, Integral, and those type of drugs that we're going to have to start. And at this point, steps are completed. Those are all the 4 steps. And the good thing about this is this doesn't have to be a nurse. This can be your multi-care tech or your nursing assistant, whatever you have, because there are some rural hospitals that everybody has to work, including your unit secretary if it needs be. But the gown, the defibrillator pads, and the groins clip can all be done by non-nursing. Of course, the saline would have to be done by your nurse, but it can be included in that step. So we're going to go ahead to the objectives, and our first objective is to add on to an already existing process. So adding to this existing process is going to save cardiac muscle by doing all the steps in less than 90 minutes. So what doing these steps and saving the cardiac muscle does is it decreases future cost. And I'm going to stop right there and talk about that a little bit. The way it decreases future cost is patient comes to the emergency room having a heart attack. If you get them upstairs, get that blockage opened, there's very little or minimal damage done to the heart, and most of that is reversible because you haven't cut the blood flow off to that cardiac tissue for an extended period of time. If you don't, and it's greater than 90 minutes, then there's a portion, whatever artery is involved, there's a portion of the heart that is damaged, and it's irreparable. It's not going to regenerate, it's not going to regrow, and it's not going to work anymore. So therefore, you have what we call a low ejection fraction. If the ejection fraction is less than 35%, and normal is usually 50 to 60, so there's enough damage that it's less than 35%, that's going to mean that the patient's going to need an ICD, which is an internal defibrillator, which probably costs between $30,000 to $40,000. Then they have to have that maintained either quarterly or biannually, which is additional copay or additional charges to the insurance and to the patient, provided they have insurance. Not only is there that cost, there's also the effects of the damage on the patient themselves. You know, sometimes this damage can make it so the patient can't work anymore. If they have a very active lifestyle or an active job where there's manual labor involved, they're probably not going to be able to continue that, which may force them into a disability situation. So therefore, this is why it's an increase on us and the hospital, because at that point they're going to be on Medicare or Medicaid, and we know what that situation is at this point in time. So this is how it can save everyone money. And lastly, it saves lives. Our objective is to save lives. And by life, I don't mean just living or dying, but I mean the quality of lives. I'm going to continue on. The rationale for this project is, at present time, and this is in all of the United States, at present time, most patients presenting directly to the emergency department or the EDs do not meet the recommended door-to-balloon time of less than 90 minutes. It's pretty surprising. I know here locally we have higher percentage of accuracy, and we've worked really hard on that, but nationally we have not met those recommendations. So any steps we can do to improve that, I'm sure is welcomed, because our goal is to save lives. And then what we would want to do after we save lives is save time. So we're going to continue on. We're going to talk about stripped, clipped, saline, and padded, and how it saves time. By saving time, by adding these steps, we save cardiac muscle here again. Saving cardiac muscle extends the life, because if they have a functioning heart, that has been damaged, you're going to extend life. And again, you're going to decrease expense for the patient, the hospital, and the insurance company. Those are all very important things in this time of recession. The other thing is, a heart attack does not mean that life is over or limited if we optimize time and the steps needed. Now, I'm going to talk to our nursing staff a little bit. The population that we're going to deal with directly is strictly STEMI patients presenting to the emergency department. You wouldn't necessarily include every patient that comes to the emergency room with a heart attack, because sometimes they're not going to fall quite into what we're looking at. You know, if they're coming into the emergency department and they're already not stable, that's a different scenario. You know, you're not going to ask those people to take their clothes off and put a gown on and take the time to do that. They're going to have a whole team working on trying to stabilize them before they even present to the cath lab. So that's a little different scenario. So we're looking at just STEMI patients presenting to the ED that are stable. How we're going to intervene is we're going to add stripped, clipped, saline, and padded. And then how we're going to look to see if we're making any progress is we're going to do a comparison. And we're going to compare the times that we do the steps and that we don't do the steps, and to see if there is a difference. Our outcome is we're hoping the outcome is the added steps will help us decrease the door to balloon time. The data evaluated quarterly based on time from pickup from the emergency room to arterial access in the cath lab. The reason that the time is from the pickup to access is because that's actually the period of time the staff can affect. We have no bearings on from the time the artery is access to the actual balloon inflation. That is actually strictly just the position. And the time before we pick up the patient with the staff, you know, cath lab doesn't have any bearings on that either. It's strictly from the time of pickup to the access of the artery, and we're looking to save that time. The evidence for change, well, this is an image of a right coronary artery that has 3 blockages. One significant blockage in the middle is probably 99%, and this is what we're dealing with. So that patient comes to the emergency room and they have this, and this can be pretty scary but can still be stable. So the standard of care for patients presenting with STEMI or ST elevation is immediate reperfusion with PCI or fibrinolysis. We don't really do that anymore. We actually take them straight to the cath lab and intervene that way. At present, most patients presenting to the emergency departments don't meet that 90-minute. They don't, so we're trying to make that better. The door-to-balloon time is considered a clinical performance measure for STEMI care in both the United States and Canada. So basically, in all of North America, that is that's the clinical performance measure. Stripped, clipped, saline, padded helps us achieve the recommended 90 minutes or less to door-to-balloon time, and also the initial steps are to discuss changes with the staff and including the emergency department and cath lab. So what I'm saying here is create a team that includes both. You know, you can't start a process that just is one-sided or only has one-sided views. So you want to get a group of folks from both departments so that you can work together and see how to implement these steps from both perspectives. So the first thing you're going to do is have an in-service. And that in-service, you're going to talk about the steps, how they can be implemented, and you're going to listen to your staff and listen to their concerns. And I can tell you initially they're going to say, well, those are minor things. Those can be done anywhere, and they can be done anywhere. But if they're done while the cath team is en route, you're saving time. So go ahead and set up the expected outcomes and implement a start date. And so these are our steps, and the date is going to be this, and we're going to start doing these steps this date. And appoint leaders from the emergency department. And what I mean by leaders is have someone who sort of buys into the plan, and they'll step and say, let's go ahead and do this. You know, let's get this done. Do the steps that we need to do. And if you do that often enough, eventually it won't be additional steps. It'll just be regular routine steps and part of the process. Other recommendations are set goals. Set what you expect the outcomes will be. Set dates of review. You're going to review these and set those dates. You're going to evaluate that data quarterly, and you're going to say, hey, okay, these are the ones that had the patches, these are the ones that didn't, these are the ones that had all of these steps done, these are the ones that didn't. So you want to take all that data and compare it, and what you really want to look at is the time, and did you meet that 90-minute or better, and our goal is better. So this is an image of a typical emergency room. They're a little blurry because everybody's moving fast because they've got to reach that door to balloon time in less than 90 minutes. And by adding stripped, clipped, saline, and padded, we should be able to do that. Talk about advanced practice nursing. Is one of the roles of advanced practice nurses is having a keen understanding of outcomes, management, and anticipate potential risks that could lead to compromised client safety and medical errors. It's very important as nurses that we find ways to help our patients and protect their safety. Evaluation of this project thus forth is based on time, because what we're trying to do is reduce that 90 minutes, and we really want to do it in less than 90 minutes. So, based on time, and based on the time we pick up from the emergency department to actual access to the artery, we're going to collect the data in a paper check form, and it's just going to be a check off with an initial, whoever does the task, and that's going to follow the patient's chart. Now, I realize they may not have an actual chart. It's a stack of papers with a paper clip. I get that. But still need to include that piece of paper with them so it will follow the patient so that we can gather the needed information and compare it. Go ahead and compare the patients with and without the steps so that we can look at the times. So the project will be evaluated quarterly, and you'll have those dates set up ahead of time so everybody knows when it's time to come together and look at that. You're going to look at the paper documentation and compile that information from the paper documentation that you've received from the patient's charts. Charge nurse from the emergency room and the cath lab will get together and collaborate and obtain that data, compare times on the patient with and without the steps, and maybe they can put their heads together and look at. Usually you have to interpret that data a little bit, but they can put it together and then present it to the team. What we expect to happen? Well, we expect our door to balloon time to be less than 90 minutes. We want that A+. We also want to have better outcomes. We want a better life for our patients. We also want better statistical reviews by providing superior care. So, shorter times, saved cardiac tissue, better statistical numbers, and a better life and better quality of life for our patients, and a better economic life for our patient. In conclusion, implementing the steps of stripped, clipped, saline, and padded will save time in getting the patient to the cath table, in which turn saves cardiac muscle. That's all of my presentation. Does anybody have any questions?
How long do you do quarterly reviews?
Well, I would expect that we would at least do maybe 6 months, so at least do 2 quarterly reviews, and then at that point, if the data is the same or it doesn't change, then you might need to add additional steps, but you need to review it at least for 6 months before you decide to change any of the steps. Any more questions?
What about if the patient comes by ambulance?
Well, if they come by ambulance and they're stable, we still can, go ahead and move them to the stretcher and go ahead and do those steps, provided they're stable. Here again, if the patient comes to the emergency room and they're not necessarily stable, we're going to stabilize that patient. We're going to do the best that we can. Obviously, we're not going to be able to completely save everybody or cover every step every single time, but we want to do the best that we can and take care of everybody that possibly we can do, and we want to implement the steps when possible. Any more questions? I thank you for your time.